So Nilesh, you gave a brilliant talk on the graft choices. So let's say you have a 40-year-old patient who's a soccer player, who's related to you. What would be your graft choice for that patient?
I think a 40-year-old soccer player, and what we need to look at it is he something into recreational sports or someone who plays more competitively. And it's not just one factor that comes into picture, just the age or what sport he plays. But given a choice, if I have to answer this in one go, I would probably think about the BTB as the first choice. If the patient is someone who says that no, he's not really into sports regularly, goes once in a while, once in 2 months, once in 3 months, then I won't hesitate to going in for a soft tissue graft, because that's something that I would do more frequently. And I think that's something which is important. What works in your hands is something which would probably be more important rather than one single answer to this.
Yeah, so Anil, I want to ask you, a lot of people have using the quadriceps graft as a primary graft for ACLs, PCLs. So what do you think of using a quadriceps graft with or without the bone plug? And that's the first question. And question two, what do you use routinely in your practice for ACL reconstructions?
I would say that, first of all, I've seen a great evolution in the Indian ACL from 10 years ago, where there was a hamstring, or a hamstring. That was the lecture. And now, to become a true knee surgeon, you need to do all grafts. And I agree, unless you don't do a graft, you're not good at it. But guess what? There's no reason why you can't get good at it. So that's the first thing. I was never trained to do a quadricep. I just learned how to do a quadricep. I don't use a bone plug. I use a full thickness graft. It's a very short, wide graft, and I meticulously repair it myself. And I don't use absorbable sutures to repair it. But I will tell you, quadriceps, although it's a great graft and it's a stiff graft, and the biomechanical properties are in between a loose graft like a hamstring to a stiff graft like a BTB, it takes a long time to recover. It takes a while for that quad to come back. So that's my only kind of hesitation now, where we got quad excited, and now on that 40-year-old, I used to put quads in them because I'm like, oh, you're not bad enough for a BTB. You're not, you want more than a hamstring. I thought quad was the middle. And I do that. That 40-year-old patient, I think all three of the grafts are the right answer, right? To me, a hamstring on a 16-year-old soccer player is always the wrong answer. But, graft choices, it's great to talk about them because we used to never talk about them in India. And now, it's great that you guys are doing more and more different grafts.
Thanks, Anil. And same question to Dr. Hatch. What is the choice of graft for a primary setup, not a revision case? What do you use, and are you a fan of allografts?
So for my primaries, on a 25-year-old, 25 or younger, I tried to do a BTB autograft. I just as Anil has said, there was a big enthusiasm about quads, but quads do come with a downside, and that's it can put the quad to sleep, and it's hard to rehab those patients, and it's a lot more collagen than we're used to. So a 10 quad is not a 10 BTB. So what happens is these patients get cyclops lesions, big grafts, because I have a bigger revision practice, and big grafts have been put in because it's just more collagen than we're used to. So under 25 years old, I'm doing a BTB autograft. Over 25, I'm doing either a BTB autograft or a quad autograft, and there's a little bit of praying that the patient's going to get their quads back on. And then I do an autograft up until around, once they get into their 40s, then it's going to be patient by patient.
Yeah, great. So Sachin, you have a question?
Yeah, I have a question on the graft choice, and we're talking about the quad. Quad has got a lot of interest now. I think definitely in North America it is gathering a lot of traction. Question to you is that, in your preoperative planning, when you're deciding whether you want to do a quad or a BTB, do you actually see the MR scan, look at the thickness of the quad tendon, look at the thickness of the patellar tendon, the length of the patellar tendon? Because when, when you harvest a hamstring, you just take what you get. And once you get what you get, then you decide what sort of hamstring diameter that you want to create. But with the quad, you have options of doing split thickness, a full thickness. With the BTB, you have a shorter, a longer graft. So do you take all these pre-operative planning sort of considerations, and how do you do that?
Yeah, Anil?
I'd say, first of all, where quad is completely replaced, hamstring is with the open growth plate. Where we used to do a lot of hamstrings, that's all quad. Quad is now the premier kid graft. Whenever I have patella alta on my adolescent to early athlete, and I would say, wow, this would be a challenging 2-incision ACL, I mean real patella alta. I'll have to flip a bone plug. Am I going to have to use a tightrope to lose interference fixation? Those times I will do quads as well. So really, patella alta is the only criteria that I use when I will switch to a quad.
You have a question?
Yes. Good morning. I had a question. I think people have been accepting a lateral procedure with hamstrings more and more, but is there a role for a lateral procedure with a BTB or a quad tend?
So lateral procedure as in?
A lateral augmentation procedure like
So
an LET or an ALL.
ALL reconstruction.
Well, I mean, you'll know from London because you guys are doing the paper. So why don't you just tell your old boss, Alan, and give us the answer? I don't know. Rick, what do you think? Are you doing a primary ACL, cutting football, USC football player? You're doing a BTB. Are you adding an LET on him? He's at Recurvatum too,
I have a low threshold for, and I'm probably biased, because my practice is I do a lot of revision. I have a really low threshold on young patients, and with the young patient, any patient below 20, I'm going to do an LET on. If they have open growth plates, they're going to get a BTB autograft, and it's going to be physeal sparing with an LET. If their growth plates have closed, it's going to be an LET with a BTB typically. If they're under 25 and they are a high-level athlete, I still will add an LET. And I think that the data is getting pushing more and more towards that. That's my bias right now. I can't support all of that, but I'm very aggressive when it comes to adding an LET for the under 25. Over 25-year-old, it's going to be kind of case-by-case, hyperextension, female. Anyone that goes to sleep with a big pivot is going to get an LET, but also I'm going to look for rotation, where the laxity is also coming from. Is it a ramp? Is it an MCL? Is it posterior corner?
Yeah, before we go to your question, I want to ask a question to Roshan. So talking about LET, and you did speak about Ellison. So in your hands, do you prefer doing a LET or do you prefer to do a Ellison procedure whenever you're talking about anterolateral instability?
Yeah. When I'm doing a revision situation and there is already many tunnels, or maybe a situation where there is femoral tunnel is on the ACL femoral tunnel is very coinciding with sometimes there can be a tunnel conversation or tunnel coalescence. And those situations, to avoid that, the Ellison procedure is very, very important. And coming back to the question he asked about the soft tissue graft, can you add LET? I'll tell you my personal experience. I have been a big fan of hamstring, and off late I started doing quadriceps in last 2 years. So wherever I have used the quadriceps graft, which is more than 10 mm size, 10 size or 11 size, those patients, the pivot shift injury goes immediately. The moment I put quadriceps graft, the pivot shift instability goes immediately. So my short conclusion of my short experience is whenever you use a big thicker graft, you don't need this. And the lateral instability will immediately taken care of. But I don't have any paper to substantiate my comment.
That's a great point, Roshan, because there are people I know who are high volume ACL surgeons and who never do a ALL, they never add a LET or Ellison, and they always rely on a thicker graft.
So, Parag,
probably internal bracing. So I agree with you.
Yeah, what I started doing, whenever I do a quadriceps, I after putting quadricep graft, I always check for pivot, and the pivot goes away.
Yeah, that's what also
And
Rick said,
with,
So I
with
think it's a
hamstring,
pre-op decision.
yeah, with hamstring it stays back. So probably with hamstring, if your pivot is staying back, you have a rationale to add your LET or ALL reconstruction. But I think with thicker graft, the dependency on this extra-articular procedures will go down, as we know the literature will change in next coming years.
You know, one thing my teacher, which Rick quoted, and it sounded like Dr. Warren was in the room, is that you never make your decision about doing collateral surgery after you fix a cruciate. And I would never make a, you know, and although it's not a true collateral surgery, I never make my decision about doing an extra-articular procedure after I finish my ACL. Because I think you know, when you're sterile and you're examining them, the leg is swollen, you never push as hard, so I think that decision should be made EUA and then intraoperative findings, and then you go. And you know, that's my decision. The one thing I've done, my approach is the same thing as Rick. I have had my fair share of women's soccer players who I'm like, oh, they're recurvatum, they're women, BTB, LET, and they've gotten stiff. So there's no free lunch. Not even at ROC, we're gonna make you pay for it, trust me. Parag will give you a bill. No, joking. So more surgery can give you more, even though it's smaller, more surgery, it can give you more complications as well.
Yeah, Nilesh, your comment and then the question.
Yeah, so I think I completely agree with that, because I think in my hands, whether to do LET is not even an EUA, it's probably a pre-op decision, because I need to consent the patient. I can't probably decide on table and then give him a scar on the lateral side and come back and tell the patient that I had to do an additional procedure.
I think 5 years, that's every case in America.
Yeah, your question.
My question to Dr. Roshan Wade. You talked about the procedure about LET and ALL, anterolateral ligament reconstruction. So in the procedure of anterolateral, you used the IT band and you fixed it to the tibial side. Did you do anything over the femoral side, or you just left it like that?
So that was when you take out the IT band, it's not ALL, that's a LET. You're using a residual IT band for your lateral extra tenodesis. When you do ALL, it has to be a free graft, either a hamstring graft, a semi-T graft, or you can use a synthetic graft depending on your situation. And the ALL reconstruction needs a reconstruction of all your ligaments with the help of the screw fixation on both sides, the femur as well as tibia. Whereas LET, you can use either one side as a dynamic side, you can use either a proximal base or distal base flap, and you can create a tenodesis. So reconstruction versus tenodesis is a effect. So I feel LET works much better in my hand. I don't believe the idea of ALL. I had never done any ALL reconstruction in my career. I don't know anybody on the panel has done ALL reconstruction here. They can enlighten.
I want to stress one of the points that Roshan made, is that if you're going to go down the path of saying my Lemare, whether above or below the LCL is better, my Ellison is better, or my ALL is better, I'm going to say good luck, because no one has that answer. There's one or two biomechanical papers here and there. I am going to say what Roshan said, is that if you actually know how to examine a knee under anesthesia, and you see there's truly a high-grade pivot, then you got to do something else. That, to me, is where the average orthopedic surgeon makes a mistake. Once you get into the weeds of those four, to me, that's not where the low fruit is from an educational perspective.
Next question.
Examination under anesthesia gives grade 3 pivot, that's a good point. But if you are getting grade 3 in OPD, that means surely in outpatient clinic, if you are getting grade 3, you need to add something.
What is your choice, Mukesh? What do you add?
Lemare.
Lemare, modified Lemare. Okay. Yes, next question.
Good morning. My question is to Dr. Mukesh Ladda in particular and to the faculty in general. It's about the complications, how to prevent them. Do you rely on soft tissue landmarks for ACL, just like the posterior round of lateral meniscus? And do you add any kind of a anti-infective thing for the ACL not to get infected? Thank you.
So there is good paper and everyone follows that. You need to soak the graft in vancomycin solution after you harvest it. Secondly, regarding your footprint, always see the remnant graft which is there on the femoral side and try to go into the center of that footprint. On the tibial side also you can see and calculate anterior, posterior and medial lateral, but on a gross way you can make an entry point just in line with or a millimeter posterior to the posterior border of anterior horn of lateral meniscus.
Yes, sir, but there was a live surgery by Dr. Anand Joshi 2 years back where he was telling the femoral footprint can be correctly diagnosed if there is a intact posterior horn of lateral meniscus also at soft tissue landmark. Just wanted to
Posterior horn lateral meniscus intact has, I think, nothing to do with the femoral footprint because it's totally devoid of any attachment of the meniscus. So remnant of ACL on the femoral footprint will give you exact position of femoral tunnel.
So I have a question to Dr. Hatch, and you did mention about the lateral side, especially the posterolateral corner injuries, where you do probably a Macintosh kind of a procedure, just a two-limb versus doing a complete Laprades procedure. When and how do you decide whether you want to do a Laprade or just, do the two-limb procedure? Mike, yeah. So
Apologies.
Laprade is you do all the way, all the three.
So you mean an Arciero type versus Laprade type?
Correct.
Yeah, so anytime biomechanically, that's been looked at, and really biomechanically, it hasn't been shown RCO versus Laprade. One's better than the other. Bob Skank showed that in their lab. Clinically, it doesn't look like there's a huge difference. However, in my hands, any patient that has a hyperextension on their injury, they're going to get I'm going to do a Laprade type anatomic reconstruction to the tibia. Many of the patients I see with multiligament injuries with posterior lateral corners do have hyperextension type injuries. And I also believe, this is my own bias, I also believe in the setting, in an ACL it may not be as important, but in the setting of a PCL, that limb that goes to the tibia, I also think gives some additional posterior support. So if I have a PCL with a posterior lateral corner, I'm typically doing an anatomic reconstruction to the tibia.
I always think that, as much as I love Bob, he can't get credit for using a Mueller bypass because Professor Mueller was the one who originally invented that procedure. And it's pretty simple to me. All the criteria you're saying, more recurvatum, looser posterior drawer, looser knee, I'm adding another cable.
Exactly.
Constraint, whether it's a total hip, a total knee, or it's a ligament, is all based off the degree of instability. More instability, you add more constraint. And you think of it that way, everyone gets that in total knee land. Oh, this knee's looser. I'm going from a CR to a PS to constrained knee, to a hinge. It's the same spectrum of how we add constraint to our constructs.
Parag, I have a
Yes,
question
last point,
about this short MCL. In fact, I asked Dr. Andrew Emis also when we met last time. How can a short MCL closer to the joint mimic a biologically longer ligament which is arising 7 centimeter below the joint line? Because the attachment of the superficial MCL is around 7 centimeter below the joint line. And in short MCL reconstruction, Andrew and Andy Williams, they claim that the more closer you go to the joint, you get a better stability.
Well, anatomically, that's correct. But anatomically, the superficial MCL actually has 2 attachment points distally. It has one that's 12 millimeters below the joint line, and it has a second that's 60 millimeters below the joint line. And if you look at the reconstructions, I'm going to say his name again. It sounds like if you look at Laprade's work on biomechanical studies, even when they were doing a anatomic MCL reconstruction superficial, they were still putting suture anchors at the joint line. And if we're thinking about this biomechanically, when we're stressing that it's actually getting stressed at the joint line. That's actually, if we wouldn't fix the fracture at 2 points far away from the fracture line. So
Yeah, so the time is up. We have one last question and then we'll have the case discussions.
Yeah, good morning. My question is, if there was LET done in primary ACL reconstruction, so will you add LET in revision scenario? That's one. And second, what should be the graft option? For example, in primary, if you have done BTB with LET, but there is failure, now in revision scenario, what will be your graft? And are you going to add some lateral extra-articular procedure?
So you're talking about a situation where a BTB graft with a LET has
done
failed.
in primary situation and it failed. So like, will you add lateral extra-articular procedure in revision scenario? And if yes, what kind of, for example.
So once your modified Lamer LET has, failed, then probably you're just looking at a revision with the ALL reconstruction. And then of course, if you use the BTB, then you're left with the peroneus graft or the quadriceps graft.
Or maybe
And then,
contralateral BTB.
Yeah, contralateral, many people don't like their opposite sides to be touched, but then yes, the opposite side graft as well. So because you've burnt your, the choice of graft when you do the modified and you took the IT band, whether you do Ellison or you do modified Lamer, the procedure for to address the ALL is gone. So you have to use a proper primary ACL reconstruction in the revision scenario.
The only thing I would add, because you've come to this conference for many years, and I recognize your face, and you're probably an excellent surgeon. So you put your BTB with the best graft in the best spot, you did an LET, and they still failed. So I'm going to say, stop thinking about doing another ACL and look at their bony parameters. Is there a coronal alignment problem? Is there a slow problem?
Absolutely.
So don't jump to the definition of insanity is what? Doing the same thing over and expecting a different result. I'm not saying you can never do a second revision, but show me that you at least thought about the other stuff.
Yeah, great. Okay, with that, we'll end the session.